Hello,
Yes, sir.
can I start now?
Yeah, 2, 4, 6, 7, 8. Yes, sir, you can start. Everyone's here.
Okay, thank you. So, good afternoon to everyone. Today we are going to discuss the total laparoscopic hysterectomy. So, total laparoscopic hysterectomy is a minimal access surgical procedure which facilitates the removal of non-prolapsed uterus through the vaginal route. If uterus is completely prolapsed, there is no need of doing the laparoscopy. You can do vaginal hysterectomy. And first time laparoscopic hysterectomy was performed by Harry Rich in 1989. And according to him, indication of laparoscopic hysterectomy is contraindication of NDVH. Because in many conditions, NDVH is contraindicated like previous surgery, endometriosis, previous CS, if there is a pelvic pain, suspected adnexal pathology, complex uterine myoma, acute or chronic pelvic inflammatory diseases, minimum uterine mobility and limited vaginal access. In those situations, ideally we should avoid doing the NDVH. And in those situations also, laparoscopy is a better option. There are few contraindications of laparoscopy also. Like if the patient has severe chronic obstructive pulmonary disease or cardiac disease, we should avoid doing the TLH. Patient has a general peritonitis, we should not do TLH. If there is a previous extensive abdominal surgery, like multiple abdominal surgeries, then also we should avoid. Hyper or hypocoagulable state, that also is one contraindication. And huge cervical or broad myoma, that is also. But remember, these are contraindications are relative contraindication, no absolute contraindication. Once you are very expert, then almost in all the cases you can perform the TLH. According to Gary and Rich classification, there are 9 types of laparoscopic hysterectomy. Type 1, you will do diagnostic laparoscopy, and once you see that there is no any adnexal pathology, everything is fine, then you will do vaginal hysterectomy, and at the end again you will do final diagnostic. That is called type 1. In type 2, you will do vaginal hysterectomy. Laparoscopy will be only used for suspension of the vault. Type 3 is LAVH, that is laparoscopic assisted vaginal hysterectomy. In this round ligament plus fallopian tube plus ovarian ligament and plus 2.5 centimeter over the broad ligament. This you will do by laparoscopy. Rest of the entire you will do vaginally. That's why it is called laparoscopic assisted vaginal hysterectomy. Type 4 is LAVH plus uterine artery. If you have taken uterine artery from above, then it will be called laparoscopic hysterectomy. But here, opening of the colpotomy, uterosacral, Mac-and-Rod, and closure of the vault will be done vaginally. Type 5, which we are going to discuss today, that is the most popular and most common. In this you will do everything laparoscopically, nothing you will do vaginally. Type 6 is supracervical hysterectomy, in which you will do the total hysterectomy. Type 7, type 8 and type 9 is used for malignancy. Type 7 is laparoscopic hysterectomy plus lymphadenectomy. Type 9 is lymphadenectomy as well as omentectomy. And type 8 and type 9 is total radical laparoscopic hysterectomy. So these are all the 9 types, and today we are going to discuss the type 5, that is total laparoscopic hysterectomy. You need a lot of hardware. First thing what you need is a telescope, 10 mm 30-degree telescope is required. Then one uterine manipulator, 5 mm grasper, one 5 mm seizure. You should have some energy sources, either ultrasonic dissector or LigaSure or bipolar, one needle holder, and some of the surgeons, they use linear stapler. In that, this broad ligament part, including uterine artery, they fire the endo-GI linear stapler. They separate the bladder, open the UV fold, and after that, white cartridge it is used, and then this entire pedicle, they will fire the stapler in one go, and it will go up to the uterine artery, and it will get divided, and it's done. Sometime even for the vault they use a stapler. Here we can see that this is the vaginal vault, bladder is separated, and here a stapler will be fired, especially in the radical hysterectomy, where upper 1/3 of vagina also you can cut by the stapler. This is a mechanical device which is used by the, the general surgeons for the cases of the bariatric surgery. The same stapler you can use here also, and you can divide it. So this is the possibility, but generally a stapler is not used. It is not recommended. Now this is the anatomy. Here we have the uterus, round ligament, fallopian tube, ovarian ligament, ureter, and this is uterosacral ligament. Already we know that uterine artery goes anterior to the ureter and vein go posterior to the ureter, and it has a descending cervical and anterior branch, and this is pararectal area. Here is the rectum, and pararectal area is divided by the ureter in 2 parts. Lateral to the ureter, which is lateral to the ureter, is called latjo space. This space lateral to ureter is called latjo space, and medial to ureter, here in this area, is called Okabayashi space. Okabayashi space. However, these spaces are important in radical hysterectomy. In TLH, we don't go that much lateral. We remain near the uterus. In the latjo space, uterine artery is dividing, and above the uterine artery is called paravesical, and below the uterine artery it is called pararectal space, lateral pararectal space. So this is the anatomy of the pelvis. Here we have 3 false ligament. This is called median umbilical ligament, this is medial, and this is lateral. Median umbilical ligament, obliterated urachus. Medial umbilical ligament is basically obliterated umbilical artery. And this is lateral ligament, that is inferior epigastric vessel. Inferior epigastric vessel. So these are the ligaments which is called false ligament. After that true ligament you have this is inguinal ligament, then this is the Cooper ligament, and this is the lacunar ligament. This is inguinal, this is Cooper, this is lacunar. This medial umbilical ligament is very important because bladder is in between 2 medial umbilical ligament. This is bladder. And we have to be careful that in this area you should not apply any hook or any energy, otherwise bladder can be perforated. After that, on the lateral pelvic wall, you have the triangle of doom. This is called triangle of doom, which has the apex is the deep ring. Medially you have a round ligament, and laterally you have Samsung artery, or it is the boundary of the triangle of pain, and this is called triangle of pain, where you have two nerves. One is called GFN and another is LFC, that is lateral femoral cutaneous nerve of the thigh. And the third is called trapezoid of disaster, where you have the aberrant obturator vessel. So we have to be careful in this area, because if your hook or anything is pricked, there may be a lot of bleeding. And that's why it's called triangle of doom. Doom word means impending death. Here is the sacral promontory, which is the highest peak of the mountain. And then we have a median sacral vessel, approximately 5 centimeter superior. Here we have the aorta. These are the two common iliac vessels. And then ureter is crossing the external iliac vessel. On the right side, ureter crosses the external iliac vessel. On left side, ureter crosses the common iliac vessel. And then this ureter is going here, and it is approximately 2 to 2.5 centimeter lateral to the uterosacral ligament. This is the uterosacral ligament. So this is the anatomy which we have to be careful during the TLH. Patient should be in the lithotomy position, and the angle between the thigh and the body of the patient, this is important, that should be approximately 120 degree. It should not be 90 degree, otherwise your instrument will fight with the thigh of the patient. Buttock of the patient should be up to the edge of the table, so that you can properly use the uterine manipulator. This is how you will perform the surgery. The surgeon will be on the left side. The camera person will be right to the surgeon, and one assistant will be here to give the instrument. And most of the TLH you can do by 3 port. Only 3 port is enough. Sometimes 4 port may be required, but most of the time 3 port you can do. Ideally, we should put the port supraumbilical, that is above the umbilicus. And how much above the umbilicus depending upon the size of uterus. But normally it should be 5 centimeter above the umbilicus. And there will be two lateral, one 7.5, another 7.5. So this is the arc of 18 and this is arc of 24. And telescope will be supraumbilical. One port 5 mm and another 5 mm will be there. This is called ipsilateral port. In the beginning, you can use 1/4 port, but later most of the hysterectomy you can do by only these 3 ports. This is the port 1, this is the port 2, and this is the port 3. Uterine manipulator is very important. There are many types of uterine manipulator. One is called Mangeshkar uterine manipulator. In this is tenaculum. Here is the tip. Different size of the tip is there, like 6 centimeter, 8 centimeter, 10 centimeter. And according to the cavity size, you have to use the tip. Better to use little smaller, otherwise it can perforate. Then this is colpotomizer. And you have a different sizes like 2.5 centimeter. Then this is 3.5 centimeter. Then here you have 4.5 centimeter. And this is called vaginal seal. That is to prevent the gas leak. This is fulcrum. And this is a knob to open the tenaculum. Once you will rotate clockwise, it closes, and once you rotate anti-clockwise, it opens. So this is called Mangeshkar uterine manipulator. Another uterine manipulator is Clermont-Ferrand uterine manipulator. Here is the tip. This is called putomizer. This is seal. And this is also one popular uterine manipulator. So I will show you those uterine manipulator. This is the Clermont-Ferrand uterine manipulator. That is very popular. Storage is marketing it. And if you see here, there is a knob. And once you press it, you can rotate it like that. And you can see when I am rotating, it changes the tip. If I am down, it becomes completely 90 degree and it is rotating like this. And as soon as you will leave this, it will get locked. And now you can do contralateral traction and you can hold it this way. So if you have to do contralateral traction, you can read like that, right, left. And if you want retroversion, just press it again and you can do retroversion, introversion, and again this is retroversion. So that way you can do this uterine manipulator. This is the Mangeshkar uterine manipulator. This is also same. As I told you, there is a knob. When I am rotating this knob, you can see the tenaculum is opening here. And this tenaculum will catch the cervix. And you have a different size of the colpotomizer. Once you buy, the company will give you all the sizes of the colpotomizer to use. And depending upon the size of the cervix, you should use appropriate size. Otherwise, it will not be possible. Like suppose this is the cervix here. Suppose this is uterus and this is cervix, then this is not fitting. And if you will use this one for this cervix, it will push the cervix. It will not push the vagina. And once cervix will push, vagina and cervix will come parallel and you have a problem. So for this size of the cervix, use this colpotomizer. And we can see now it is nicely entering. So correct the size of the colpotomizer, and it should not be too much loose also. If it is loose, then also you have a problem. So what you will do, you will introduce this tip inside and then open the tenaculum. We can see tenaculum is opening. And then it will take a bite over the tenaculum. And tenaculum is closed now. So once this bite is taken and on the cervix, after that you push the colpotomizer and colpotomizer will enter. And now this is the anteversion, retroversion and contralateral. You will hold this fulcrum. And this is retroversion, anteversion and contralateral. This seal should be in the being outside. You will push it into the vagina only at the time of colpotomy so that gas will not leak. And this is called another uterine manipulator. This is called Marva uterine manipulator here. In this there is a knob and you will put the cervix in it. And you have the different sizes of the colpotomizer comes with that. You can see all the different sizes of the colpotomizer. So you will use that one. And suppose this colpotomizer is good, then you will put it like that. And then it will introduce into the cervix. After that, you will just push all of them. It will go to the cervix and then tight it. And that's all you can do. Anteversion, retroversion, contralateral traction. This is also one type of uterine manipulator which has an inbuilt colpotomizer. Sometimes you have the half circle colpotomizer also. This is called half circle colpotomizer. Suppose you have a large cervix, doesn't fit on the full service, then you can use this one, half circle colpotomizer. And it has a rotation also possible. We can see it is bending. Once you rotate, it becomes straight. And then when you rotate clockwise, it bends in the opposite direction. I will show you, see it is bending, and it is bending in the opposite direction like this. And it can articulate, and this articulation is possible like that. When I am rotating, it is articulating. So this is also a good uterine manipulator. After that, you have a roomy uterine manipulator, in which once you will rotate clockwise, it will do antiversion. You will rotate anti-clockwise, it will do retroversion. So this is also a good uterine manipulator. And this is called forceps type of uterine manipulator, where when you will open, it closes, and when you closes, it opens. This is forceps type of uterine manipulator, in which what you will do, that you will put this into the cervix and then just lock it, that's all. Now cervix is just over here, and then it can do anteversion and contralateral traction. So once you hold it, it doesn't come out, it will hold. And if you have to remove it, just open this and then it comes out. So this is a very simple forceps type of uterine manipulator. So many type of uterine manipulator is available, and depending upon the availability in your country, you can use any type of uterine manipulator depending upon the situation where you want to use. So Clermont-Ferrand uterine manipulator is marketed by the Storch, and this is the maximum used uterine manipulator, and which is a reusable. You can reuse it, autoclavable. It can be autoclaved. Now, United States of America, where we are sitting right now, this is most popular is the roomy uterine manipulator. It has two balloons. This balloon is called uterine balloon, and this balloon has 10 ml capacity to put the saline, and this is called vaginal balloon. And this part of this uterine manipulator is disposable. You have to use only one time. So this is very good because gas doesn't leak at all. And this also has different sizes of colpotomizer which comes together. And here you will rotate it and it will do anteversion and contralateral traction. You can see this is a uterine balloon and this is the vaginal balloon. They will also give you one cervical sizer. Once you will hold the cervix, it will let you know that which size of the colpotomizer will be appropriate. To choose the colpotomizer, it will help you. So you can do anteversion and retroversion. We will see this small video of this uterine manipulator, how to use it. So this is the Rumi 2, that is the second generation. They will give you different sizes of the tip, like 4 centimeter, 6 centimeter, 8 centimeter, 10 centimeter, 12 centimeter. And it has two balloons. This balloon is 10 ml, this is the 50 ml balloon. And you will attach it. After that, you have a different size of the colpotomizer, like 2.5 centimeter, 3 centimeter, 3.5 centimeter, 4 centimeter. And according to size of the cervix, you choose one of them. Then you will introduce it into the uterus. and after that you will put 10 ml saline, and this will inflate. Purpose is it won't come out and it will not allow the uterus to rotate. But you should take care that tip should not touch the fundus. There should be a 2 centimeter gap should be there. Because purpose is just to hold the uterus, not to give cranial traction. Cranial traction will be given by colpotomizer. And then you will push the colpotomizer and lock it. There is a lock here which will be locked. After that, you can do anteversion, retroversion, anteversion, retroversion. And once you have reached to the colpotomy part, then you will put 50 ml saline, and this will be distended. And then you can do colpotomy. This is cervical sizer. Once you will hold the cervix into that, this cervix, then it will let you know that which size of the colpotomizer will be appropriate. We can see here 2.53, 3.54, all the sizes. You have to put also the sound so that you can select the appropriate length of the silicone tip. You can, this is 3.75 centimeter, 6 centimeter, 8 centimeter, 10 centimeter, 12 centimeter. This is the length of this tip which you have to select according to the size of uterus. This is marketed by the Cooper Surgical, the same company which is making Filcy clip also. It is available in the United States of America, and almost all the country you can find it by Cooper Surgical. It has 2 tubes outside in which you will distend the line. And then you will push the colpotomizer to encircle the cervix. Such will come completely inside the colpotomizer. And then there is a lock here. This is a lock which you will lock it. Once you lock it, this doesn't come out. So it is done. After that, you can start doing the hysterectomy. Here, this is a part which should be locked. This is one more demonstration of the same uterine manipulator. Jerk to nahi hai. So we can see these are the different sizes of the colpotomizer. You will hold the cervix. Then you have to put a sound to know the size of the cavity, and you have to dilate up to 5 number of Heger dilator. After that, this is the disposable part. That is a silicone tip which you will apply. And this is a balloon of 50 ml. And on the tip there is a 10 ml. You have to put a seal also so that this metal part will be covered. And there will be no direct coupling. Now you can do anteversion, retroversion. And this is the colpotomizer which you will attach. This is anteversion. And then you can do retroversion. This is retroversion, anteversion, retroversion, anteversion. And then it can also rotate right and left for the contralateral traction. This tip will be, this is a balloon here. This you will inflate 10 ml saline, and this will be inside, and cervix will be in this colpotomizer. So correctly introducing the uterine manipulator is an important part of surgery, and this is contralateral traction what you will do, and then cranial traction. So these all type of uterine manipulator you have to either you do yourself, or your nurse has to be trained enough to put it for you, because wrongly placed uterine manipulator disturb the surgeon, and surgeon has problem in the performing surgery. So appropriate size of the tip and appropriate size of the colpotomizer. Colpotomizer should be tightly fit around the cervix. It should not be loose also, and it's not a small also. It should be optimum size. So we can see here that this is introduced. After that, just demonstrate you can lift it, and you can see the colpotomizer is nicely fit all around the cervix, and cervix is inside the colpotomizer. This is a 3.5 centimeter colpotomizer which is used here in this case. So this is how you will use the uterine manipulator. This is the Clermont-Ferrand uterine manipulator. This is also similarly used, but here your patient buttock should be up to the edge of the table, and you will use this uterine manipulator. So this is also a good uterine manipulator which can be used, and here how you will rotate right and left, and patient buttock should be up to the edge of the table. And then contralateral, and this is for anteversion. You will rotate it down, it will do anteversion. So it acts as a lever action, and this is the colpomizer. We can see here. This is the, once this knob will be at 12 o'clock, downside it will go 6 o'clock. Here, this is the colpotomizer tip. But this is half circle. This is half circle. Half circle has a problem that sometime it go away from the cervix. So you have to be careful that you should remain near the cervix. Otherwise, you can completely cut the uterosacral and you can do vaginal shortening. So full circle is better. Half circle has a tendency to go away from the cervix. This is the half circle colpotomizer. But half circle is good in some cases where you have the cervical, some fibroid which has a vaginal extension, or very bulky or very lacerated cervix where full circle is not possible, then half circle can be used. And during colpotomy, you will put a seal. It has a circular seal so that gas will not leak. So we can see here that upper pedicles are done, and now before doing colpotomy, you will push this seal so that gas will not leak. And then you can start colpotomy. While you are doing colpotomy, your assistant will rotate the colpotomizer, and that will facilitate your colpotomy. Because it is half circle, so you have to remain within the ring of the colpotomizer. An assistant has to rotate it corresponding to your colpotomy incision. Once the colpotomy is over, then it will take the uterus out to the vagina, and after that all the gas will leak. So you have to stop the gas leakage, and there are three ways of stopping it. One, this is called vaginal plug. This is available. Those are silicone. This is called vaginal plug, which you can push and it will block gas leak. Another way that you can use some sponge in the gloves and you can pack. And third way that you can push the uterus itself back in the vagina, only the fundus and corpus part, and then also gas leak will stop. And then it will facilitate your suturing. So this way different type of uterine manipulator has to be used. Now movement of the uterine manipulator is very important. When you are using the right round ligament, fallopian tube, ovarian ligament, then uterus should move at 9 o'clock. For left, it should be 3 o'clock. For anterior leaf of the broad ligament, it should move 5, 6 and 7 o'clock. For bladder separation, again it should be 6 o'clock. For the posterior leaf of the broad ligament, it should be 1, 12 and 11 o'clock. For left uterine artery, it should be again 9 and 3 o'clock. And for colpotomy, 6, 9, 12 and 3 o'clock. So this is how movement will be done. So we will start the surgery and we will see how to perform. So this is the patient, and here supraumbilical varus needle is introduced. Now you will do irrigation, suction and hanging drop test. This is irrigation, suction and hanging drop, just to check your varus needle is in correct place. After that, you will start insufflating the abdomen and pneumoperitoneum will start. Now we can see here preset pressure was kept to 15 millimeter mercury and abdomen is distended. After that, you will remove the varus needle, enlarge the incision to 11 mm, and then you will put the first port, that is the 10 mm port for telescope. This is the optical port. And then you will introduce the telescope and do the initial assessment of anatomy. And you have a two arc. This arc is 18 and here this is 7.5 centimeter lateral to the umbilicus, and then again another will be here, that also 7.5 centimeter. So these are the three ports which is required to perform surgery. And this is the last port, that is the third port. Once all the port has been introduced, then you will put the steep Trendelenburg position. Head should go 30 degrees down and table also should go down. That is called a steep Trendelenburg position. Head down and table down, so that your hand of the instrument should be at the level of elbow. After that, you should push all the bowel above the sacral promontory by the shaft of the instrument, and you will get everything clear. We can see here that it is above the sacral promontory. This is aorta, This is common iliac vessel, and this is called aortoiliac axis. This is the aortoiliac axis. Here is the ureter going. This is ureter. This is of course appendix. This is sigmoid colon. And here will be the sacral promontory. So you will use all the anatomy and take some time to do diagnostic. So we can see this is the common iliac vessel. This is the ureter. This is the sacral promontory. Here is the sigmoid colon, and here is the left ureter. This is the left ureter going. You can see the peristalsis. Then this is the triangle of doom, and this is the external iliac artery. Here is the deep ring, and this is round ligament, and this is GFN, that is branch of genitofemoral nerve, and this is the iliac artery. Here will be the triangle of pain, where you have a GFN and LFCN, that is lateral femoral cutaneous nerve of the thigh. This is the deep ring, and here is the inferior epigastric vessel going. This is round ligament, and this is inferior epigastric vessel, this one. This is the inferior epigastric vessel going. This is the round ligament, and here this is the part which is Cooper ligament, that is the also called lighthouse. This is the area of Cooper ligament, and this is the pubic tubercle. Here is the median umbilical ligament, this one. This is median umbilical ligament, that is obliterated urachus. And this is the medial umbilical ligament, that is obliterated umbilical artery. And this is inferior epigastric vessel, that is lateral umbilical ligament. And this entire area belongs to bladder. This all is bladder. This all is bladder. It is deflated, so it looks like too distant, then it is in between two medial umbilical ligaments. These are the two medial umbilical ligament. And this is the median. And this is the round ligament here, this side. So this is the anatomy. Now this area belongs to bladder, and this is uterus. Here we can see this is the cul-de-sac, and this is the uterosacral ligament. This is the uterosacral ligament. Some fluid in the cul-de-sac, that much is normal. Here this is the uterine artery. This is the uterine. And here is the uterosacral ligament. This is the gray area. If we have put the marceline tape or we have to ligate uterine artery, we put the needle in this part. So this is the anatomy here, posteriorly. After that, coming to the left side, you have the iliac vessel. This is the left iliac vessel, that is external iliac artery, and this is psoas muscle. Over the psoas muscle, this is external iliac artery and vein, and this is the round ligament. This is the vein. Vein is medial, and this is the artery. That is the external iliac artery, which is visible. After that, here is the nerve, that is GFN, and this is the inferior epigastric vessel of the left side. So this way you spend some time to do diagnostic, and it is better that all the anatomy. Here will be the inguinal ligament. Inguinal ligament not visible, you can only feel it. So this, after diagnostic laparoscopy, you can start the hysterectomy. And if you want, you can use infrared ureter catheter. Generally in our setting, we use infrared ureteric catheter or ICG, that is indocyanine green, and this is the infrared ureteric catheter which we are putting. It is not necessary to use, but for educational purpose, if you will put it, it will be better, and it will almost make your surgery without any risk. 15 centimeter of this infrared. How you will know 15 centimeter? You will have 3 black line, and if there are 3 black line, that means it is 15 centimeter. So you will put the either ureter. It is just a 2-minute job, and this is now the left ureter. This is the infrared ureteric catheter which you will push. On either ureter, and then you can start the surgery. So either side 15 centimeter it has to be pushed in. And then you can see it is blinking. Both the side, this is the ureter. Entire ureter will get illuminated, and it is difficult to injure the ureter because it will keep on blinking, and mechanically also you can touch, then you will feel the hardness. Now uterus will be pushed cranially by the uterine manipulator, and then you will start 4 centimeter lateral, that is 432. Round ligament 4 centimeter, fallopian tube 3 centimeter, and ovarian ligament 2 centimeter. Many people, if they have to do BSO, they directly start with the IP ligament, but we don't. So if we have to remove the BSO, we do at the end. Because you cut it from here, there will be 2 problems. One problem, this tube and ovary will keep on hanging with the uterus, and it will disturb you a lot in the vision. And you need an assistant to lift it up. And another reason that it will be obstructing the uterine manipulator. Now, in the upper pedicle, you should remain at the level of ureter, round ligament, so that once you will open the peritoneum, you can lateralize the ureter further. It is not wise to remain very near to the uterus in the upper pedicle. So this is the round ligament done. And you can see here that uterus is at which o'clock? 9 o'clock position. And it will be cut like that. So it is very important that your assistant should be very intelligent to do the uterine manipulator. And it should do nicely. And this is fallopian tube, and after that this is ovarian ligament. And then you will go 2.5 centimeter over the broad ligament. More than 2.5 you should not go without opening the peritoneum. Otherwise here we can see this is ureter. So maximum can go 2.5 centimeter. So this is done. Right side. After that uterus should move at 3 o'clock position. And again you will do 432 of this side. Left side. And uterus we can see, now uterus is completely contralateral, and this is 3 o'clock position. 3 o'clock position. And then again 432 will be done this side. So it is very important that your uterine manipulated person should have coordination with your surgery, and he should know all your movements. This is the fallopian tube. and then ovarian ligament. And then you can take the 2.5 centimeter over the broad ligament maximum. Further you should not go because you can see here is the ureter going. After that you will push the uterus at 5 o'clock. With the left hand we have to stretch the peritoneum, and you will keep on cutting the peritoneum, and while you cut the peritoneum, uterus should move from 5, 6, 7 o'clock. Assistant should move the uterus slowly, and you will keep on. Left hand is very important to do the lateral window, and it should keep on stretching the peritoneum while you are progressing from left to right. And slowly keep stretching, and then you will keep on cutting. So it's done. After that, you will lateralize the peritoneum. Now next step is that you have to separate the bladder. Do you know this all is bladder here? This all is bladder which you have pushed down bluntly, and you have to push it bluntly with the tip of the grasper. And if you are using harmonic, then keep the tip, otherwise it can penetrate into the bladder, and this is colpotomy. And remember, if there is any fat belongs to bladder. Actually fat belongs to organ. Fat always should be, fat belongs to rectum, fat belongs to bladder. And always remember that vagina is recognized by the criss-cross pattern. That is called criss-cross pattern over the pearly white vaginal fascia. So we can see this is vagina. How it is recognized? By the pearly white background, and this is criss-cross pattern of the vessel. And this is very important that your bladder pillar also should be properly lateralized. This is lateralizing the bladder pillar is important. At least 2 centimeter laterally you should push. We can see here, this is ureter. And if you will not lateralize, then right now there is a infrared, that's why we are seeing. But even if it is not there, then it will be there. So you have to lateralize. It is very important step. After that, uterus will go at 1 o'clock position, and similar to the anterior leaf, you will make the posterior leaf of the peritoneum. And left hand should always stretch the peritoneum inferomedially. This is called inferomedial traction. And then you will cut the peritoneum. And while you are cutting the peritoneum, assistant will keep on moving in this direction. He will keep on moving the uterus by colpotomizer. We can see this is the uterine vein. And you should try not to touch it, and always only peritoneum will be cut, nothing else. This is the vein. And only peritoneum should cut. And once you are moving the peritoneum, automatically your assistant will keep on rotating from the right to left. And once you are taking left side, it will make. So it will automatically keep on cutting the peritoneum. And now uterus is 11 o'clock. So posterior peritoneum is pushed down, and now this is a time to take uterine artery. When you are taking the uterine artery of the left side, uterus again should go at 3 o'clock position. You can see here that this is a circular tip, and that tip is very important, this tip. And just by seeing this, you can know that which direction your telescope is showing. So 30-degree telescope, light cable should be towards the left, so it will show you right. And uterus should go contralateral traction at 3 o'clock position. After that, you will take care that generally in our practice, we put a lot of betadine in between the jaw of the LigaSure after cleaning it by the hydrogen peroxide. And either bipolar or LigaSure, you put a lot of betadine. What is the advantage of this? It doesn't allow any smoke to come, and it will not allow any pedicle to get stick with your LigaSure. So that is very good practice. We have published one paper also in the World Journal of Laparoscopic Surgery that applying the betadine in between the jaw of the LigaSure or bipolar, efficiency will increase and it will not stick with your tissue. No charring will happen. And coagulation will be better because bipolar efficiency increases if there is a fluid inside the jaw. So we can see this is over and now this is the uterine artery here. So this is the uterine of the left side is coagulated. Now again uterus will move the 9 o'clock position and then you can coagulate the right uterine artery. So this again you will go with the LigaSure and your tip of the LigaSure should almost touch the colpotomizer. We can see here this is the colpotomizer and it should almost hit the colpotomizer. And there should not be any muscle bladder at the level of tip. That is important. Otherwise your uterine will not coagulate efficiently. It should be properly skeletonized. And it is done. Sometime if vein bleeds, vein is posterior so it bleeds, then you may have to coagulate little nearer to the uterus and this is done. After that, now this is the time for, this is uterine artery here, this is the uterine of this side here, this is the lumen and both the side of uterine is nicely coagulated. So this is 3-port, that's why your assistant need a lot of contralateral traction and uterus should be fully contralateral traction. If you have a 4-port, then that side should be done by the other side. Now this is colpotomy. We start colpotomy, we don't cut the vaginal part of uterosacral. So this is the uterosacral ligament and we start above the uterosacral ligament to do colpotomy. We don't cut this. It is not good to cut because that will increase the chances of wall prolapse. However, cervical part will be cut, but vaginal part is not cut. And now this is the colpotomy. While you are doing colpotomy, assistant will keep on rotating the uterus and you will do a lot of cranial traction. You can see vagina is pushed so high that you can see it is reached up to the uterine vessel. So a lot of cranial traction is very important. You should have a very good assistant who should give you a lot of force to do the cranial traction. And this is the colpotomizer. And you can see that vagina is pushed so high that just you touch with the hook or a spatula or by a harmonic and it will split. Another advantage that you can see ureter has gone so down like here and bladder is also way. So giving cranial traction is very important. You should use a very muscular nurse to do the uterine manipulator. You should not use a lean and thin nurse. So, and they should never be able to sit. They should allow to remain stand and pushing it. You can see here, this is the vaginal part, uterosacral ligament. We don't cut, we cut it from here. And that's why in our cases, we have the no wall prolapse in TLH. LAVH or NDVH has more wall prolapse because without cutting the uterosacral ligament, you cannot bring it out. So this is how you will do colpotomy. If you have some oozing, that may be the reverse bleeding, that is collected blood. For that you should not worry. Once you will cut it completely, then it will stop. So it is over. Now you can pull the uterus out. After that, you have to remove the tube. And here tube is removed. Now what you will do? That this is the IP ligament, this is the IP ligament, and this is the IO ligament. So if you have to apply here, then tube will come out. If you apply here, then BSO will done. So this is for BSO and this is for only salpingectomy. So now you have a lot of free space, so you can give inferoentromedial traction. Your patient will give traction, and then within, this is for BSO and this is for removal of the tube. And within just one go, tube will be easily coming out. We should try to remain more nearer to the tube to prevent the devascularization of the ovary. So tube is cut and it is removed. After that, you will remove the tube of the other side. Again you will give the enteromedial traction, and again this is IP ligament, this is IP, and this IO. So you will cut it from here. One hand will give enteromedial traction and other will cut the. You have a free space and easily you can give the traction. And it is done. After that, you will bring the suture through the vagina here. This is a stone holding forceps. This forceps is called a stone holding forceps, which is used by general surgeons to hold the stone. That you can push it through the vagina by the side of the gloves. It will slide because tip is here. We can see this is gloves. This is gloves, which is packing the vagina, and by the side of that, this stone holding forceps will come, and you will pull it out. Then you can push the suture also through the vagina itself with the needle, and this is number one vicryl, and then you will start suturing. You should suture it very nicely. The first bite should be taken on the uterosacral. This is the uterosacral ligament. Here is the uterosacral of the right side, and the bite is taken in the posterior vagina. Because you don't have assistant, so you have to hold yourself and you have to take bite also yourself. But in the beginning, if you have assistant will do. This is the gloves you can see, and you should also be careful that you should take full thickness vagina with the epithelium. Only fascia should not be taken. If only fascia you will take, there is a chances of granulation tissue formation, and you have a spotting for many months. Bladder has to be pushed down while taking the bite so that bladder should not be pricked. And we don't tight it, just keep it loose. First bite should be loose, only 3 bites, and this is another uterosacral ligament. This is again uterosacral ligament of the left side. So you will take a bite, but take care that don't go too much lateral. And after that, this is anterior. So this is a simple without locking. You don't have to lock it. And once you come on the left side, then you should lock the suture. Go through the loop and take the needle out and it will get locked. So it is pulled and then it get locked. Once it is locked, then you should pull the tail again to make the first layer tighter. So just hold it and pull the tail again, and it will make it tighter. If you have assistant can keep it held. So it is now tight. And after that, you will start returning back. So you will catch the needle and then start returning back. Once you start returning back, then every time you should lock it. And what is the advantage of locking it? That it will not have any loose gap in between, and it is nicely locked. And this way you will keep on locking it. So in returning, every time we should lock it, and this, after locking, this suture itself will give cranial traction. So this is a unedited video. Here we have not done any editing in the surgery, and it is a skin to skin video. Only the part which was used for cleaning the telescope or defogging was cut. Otherwise, entire surgery is a real time surgery. And this is returning knot, and you can slowly return back. So this is when two layer suturing. First row we have done without locking, and in the returning row it was locked. Take care that once the needle is near the iliac vessel, don't try to play, put it over the rectum and then press it by the upper jaw to align the needle. Now again the bite is taken over the uterosacral ligament, and this is the final bite. And again, as soon as you will bring the needle through the loop, automatically it get locked. So this is the final, and after that you can terminate it by the surgeon's knot. So just you can make C, reverse C, and tight the first layer again, and then you can tie the knot. So you have to rotate to make a loop, and then left hand will be stable and right will take two loose wrap. Sorry. And after that it will hold the tail and you will slide it. Any shoe latch should be opened. Now you will make a reverse C. Here we can see that this was the same fluid which was in the beginning in the cul-de-sac. In this surgery, we have not done any suction irrigation throughout the surgery, and there was no any blood loss. So once it is done, after that this suture will easily go out with the 5 mm port also. What you have to do, you have to hold the suture and get everything out. Through the port it will not go, it will go through the port wound. After that you will cut the suture and then pull the suture in the cannula, and then even the cannula also will be taken out. All together you have to come out, and it is pulled. So this way you can perform. Now this ureteric catheter already is hanging outside the vagina, so directly you will pull, it will come out. So you can do final diagnostic and that is over. So this way you can perform the total laparoscopic hysterectomy by 3 ports. This is one, second and third. There is no port on the side. So before going to the complication, I will discuss now complication. But before going ahead with the complication, I will like to have any question regarding the operative procedure and then I will discuss further. So if you can ask any question, then it will be appreciated.
Is there any question? Okay, do you make bowel preparation, sir?
No, we only keep the patient kneel orally prior to the night of the surgery. Bowel preparation, if you want, you can give pegleg powder, that is polyethylene glycol, 1 or 2 sachet, depending upon the weight of the patient prior to night of surgery. Pegleg powder has polyethylene glycol that can be given. It comes in the sachet. But the problem of pegleg powder is that it distends the bowel sometime. So that's why we don't use it, because using it has some risk. Because nitrous oxide has a problem that it distends the bowel, especially empty bowel. So if you are using isoflurane, then it is better. Then you can use this pegleg powder. But generally in our setup, we don't use it. This is the peglag and that is very good and that you can give. Advantage is that it will create the gastrointestinal lavage. This is polyethylene glycol and it has electrolyte also. So if you want, you can give it, but generally we don't give it because we only keep the patient kneel orally, only on the liquid, kneel orally prior to the night of surgery. And we don't do bowel preparation in TLH. In radical hysterectomy, bowel preparation is required, but for TLH it is not necessary.
No le dan nada, nomás la dejan en ayuno la noche anterior y tanta.
O sea, de la cúpula vaginal solo queda suspendido por lo que usar.
Sí, so the vaginal cuff, it's only suspended by the uterosacral, right?
Yes.
After the TLH.
Actually, he wants to ask another question. He wants to ask that what you are doing for prevention of the prolapse of the vault and what suspension you want to do. Remember, here no suspension is required because we don't cut uterosacral at all, vaginal part. In the abdominal hysterectomy or vaginal hysterectomy, you are approximating the uterosacral or you need to have some suspension, either sacrospinous fixation or anything. But here we don't need to do, and even cord we don't approximate because we are not damaging the vaginal arc of uterosacral. So you don't need suspension. However, if the patient has already grade 2 or 3 prolapse, then you need suspension. Then you can do even TLH together with the sacrocolpopexy also. But normally in the normal uterus where it is not prolapse, in the TL, one of the biggest advantage is that post-operative chances of prolapse is not there because the arc of uterosacral, NDVH or LAVH, without cutting the entire uterosacral, you cannot descend the uterus. Uterus will not come down if you will not cut the uterosacral. Either side you are clamping the uterosacral, cutting it. But in TLH, we don't damage the arc of uterosacral. Only the cervical attachment is cut. Vaginal arc is maintained. So that's why we don't need anything suspension. So
Two questions.
Yes.
Thank you very much for the presentation. The fourth question is, you recommend you do laparoscopy and bilateral rectum before we do laparoscopy before we do our procedure, Second question is the BMI of 45. Probably need a hysterectomy for a benign reason. What's your advice in that situation? Should he be keen on saying, is your BMI to less than 30 plus 5 before we do it, or we can say, look, an expert, I'll give it for BMI 45?
Okay. So the question is that if you recommend to do urethral canalization before the TLH. And the second question is, what would you recommend in a patient of 45 of BMI that needs TLA hysterectomy for benign reasons? To ask for her to lower the BMI, or you say, okay, I'm an expert, I will do it?
It will be very difficult for the first question regarding the ureteric catheterization. Ureteric catheterization should be only done after putting the port. Once you have done the diagnostic laparoscopy, then only, and it is not necessary in every case. However, in the beginning, if you will do, then it will be very safe surgery. Another, you can use ICG also, that is indocyanine green, that also help a lot. And that is not mandatory here, just for educational purpose I have shown you, but it is not necessary that every cases catheterization should be done. Now for the BMI, if you think that patient will decrease the weight and then you will do TLH, then I don't think that it will happen, because patient has no that much motivation. Otherwise she should not have gone at 45 BMI. And you should do TLH anyway, and for that you should use 45 centimeter instrument, that is a bariatric instrument, because with the normal instrument it will not work. And another, that you have to use a good uterine manipulator, and then with little experience I will not suggest you to take a 45 or more BMI in the beginning of your surgery, but after doing at least 50 surgery TLH, any BMI you can perform. And sometimes laparoscopy is easier to perform in the morbid obese patient compared to open surgery. In open surgery, it will be very deep uterus, very difficult to pull it out. Laparoscopy is easy for the morbid obesity patient. And of course, you need little more means steep Trendelenburg position and uterine manipulator. And sometime you may need one additional Maya screw also sometime to pull it up, but can be performed the laparoscopy in any BMI of the patient.
Yes.
So we talked about green.
Indocyanine green.
So we is el pone en la vejiga y eso por ver.
Yes. No, you have to do. So the question is about the indocyanine green. How would you use it?
Indocyanine green, same way you will put the catheter and you inject the ICG, and that's all. After that, entire ureter will keep on looking and it will give you very green good color. I will show you that indocyanine advantage, that it can show you artery also, but for the artery you have to inject it directly. So I will just like to show you how it is done with the ICG. So, but for that you need a special camera, that is the advanced camera, which is ICG compatible.
Assistant will keep on.
You can see this is the ICG camera, and here it gives you very beautiful color. I will show you. In ICG you have a different mode. These are the mode here. You can see overlay mode, CSF mode, contrast mode, ENB mode. These all modes are available, and you can see here, just you have to press one button and you can see this is CSF mode, in which this is ureter is visible, and it has an augmented color. So you can see that this is the ureter. This is now contrast mode. In the contrast mode, it will look white and surrounding will look black. This is contrast mode. This is called ENV mode. In ENV mode, all around it will show you gray and the ureter look completely green. So in our surgery, many times we put ICG and it will be completely green. And here you can see entire ureter will be beautiful visible as a green color. And you can increase the intensity also more or less. And this is called overlay mode. In overlay mode, surrounding will be color and it will look green. And again, this is called SPI intensity. You can increase the intensity. And if you want to see artery, uterine artery, then directly you can inject the IV and then even the uterine artery can be visualized. So this way IG is also done same way as infrared, but what is done that after injecting it, we take the catheter out. You don't need to remain catheter throughout the surgery. So, but for ICG, you should have a advanced camera. But illuminated catheter, you need only infrared light and you can have the U kit. It is available in the market and Striker, Stars, all is making the U kit. And you don't need any very advanced camera because any camera can show you the infrared. So this is available by the name of U kit and this is called U kit. This is the U kit and it is available with the Striker, Olympus or making. And this is U kit here. This one. This is called lighted ureteric stent here. And this is the catheter which you have put it. So any camera can show you. Only you need a infrared light source which is easily available. Even if you have existing camera, you can use infrared ureteric catheter. But for ICG, you need the recent camera. But if you have any new camera you will buy today from any company like Olympus, Striker, Stars, Wolf, all has ICG capability today if you will buy the latest model. But if you have an old camera, then unfortunately ICG is not there. In that condition, you can use the infrared ureteric catheter or even you will put simple ureteric catheter. Even if you put a simple ureteric catheter, that will cost you hardly, $10. Not even $1, it will cost you $2. Then also, injury of ureter can be prevented because you will feel the tactile feedback. If you try to close the LigaSure, jaw will not close because the catheter inside will obstruct your jaw to close. So using any catheter can be very promising and it will prevent the injury. So any other question?
There no question.
So now we'll go to the second part of the surgery little faster. That is the complication. I will show you a few of the complication of the TLH. So TLH is an important surgery. So it is one thing more I want to tell you. There are new robot has come that is called V nodes. This is just for information that this robot has advantage that you can do the TLH through the vaginal without struggling, and you can push this cannula through the colpotomy wound, means through the vagina, and through that there are 3 instrument can introduce and they completely get complete. It can rotate 180-degree backward and then you can perform TLH with the V nodes. And this is the Harmonic company, that is one company which has started making this robot. and you don't have to struggle because you will sit, and this is hominis, which is making the vaginal robot. And you can do TLH, you can do myomectomy and all the surgery vaginally, and that is called V nodes. So this is also very good, and you can use in the latter and in the future, and there will be no scar, and in the future the surgery of the vagina can be performed, and already surgeons are doing the vaginal route for the cholecystectomy, appendectomy, that is called NOTES, natural orifices transluminal endoscopic surgery. Now, sometime to extract the uterus, there will be a problem. So you have to bisect the uterus in two half. So you should do the cervix by a tenaculum or Elis forceps, and the cervix you should bisect in the two half. And after that, on the corpus part, we should not bisect, we should give V-shaped incision. So this is cervix, you will divide equally, don't do asymmetrical, otherwise it will break. And this is now the corpus part, and in corpus part you should cut it V-shaped like this. Anterior and posterior should cut separately. So you will hold it by the Elis forceps, and then you can do the V-shaped incision. First you should take anterior and then you take posterior. And then slowly you can divide and you can cut it. So it has an advantage that even the large uterus can be taken out. So this is the anterior one. After that you will do posterior. This is posterior. Posterior again you will do V-shaped and you will keep on cutting it. So this way you can morcellate. And if there is any fibroid, then also. And traction should not be given here on the pedicle. Traction you should give by holding a Elis forceps. And assistant will only hold these pedicle cervix. He should not pull it a lot, otherwise it breaks. And slowly you can morcellate. If there is any fibroid, that also will come out. Like you can see here, there is a fibroid here. That also will come out. And then slowly it can be taken out. So larger uterus, and if it is a very large uterus, then you need morcellation. You have to morcellate it. So this is vaginal morcellation, but if it is very large, you can use laparoscopic morcellation and you can take it out. So it is the extraction slowly you will perform. So this is also possible and one of the good options to remove the large uterus. And once the size will reduce, then automatically entire uterus will come out. And it is out. So other complication is bleeding. Here we can see this is the overcooking and it is bleeding started. Now once you will try to catch it, this is how we damage the ureter. So we should try not to do that, and it is important that you should not blindly go and catch it. Otherwise there will be a problem. Another complication is that sometimes it starts retracting back. And if your peritoneum is not nicely lateralized, then it will start hiding in the fat, and then if you go nearer, it will damage the ureter. This is how we injure the ureter. So in those situations, we can see here ureter is already damaged. It is cut and ureter is damaged. Now in this situation, you should stop the hysterectomy and you should try to repair the ureter. Uterus should not be removed. And you can see this is ureter, which is lumen is there and it is cut already. This is a bladder end, this is this end. So now what you do, you should immediately suture it. Just like how you do tubal recanalization, first bite should be at 6 o'clock with the 40 vicryl. That is out to in and in to out. You will take 6 o'clock bite and you should suture it. The posterior approximation. That is posterior wall, 6 o'clock. After that, you should use a DJ stent laparoscopically. This is double J stent. And one end you can put this side. If you can do this is good, otherwise you may need a good urologist. So urologists also should know how to do hysterectomy, because then only they can help the gynecologist. So here this is a DJ stent, and then you can take 2 more bite at 2 o'clock and 10 o'clock position to approximate the tube, ureter. But it has a high chance of stricture. So later, once the stent will be removed after 21 days, then self-expanding metal catheter is required to prevent the stricture. And sometime if a stricture happens, there may be necessary to do the ureteric reimplantation. But at least at this time, patient will be safe and there will be no ureterovaginal fistula. So it is always better to repeat. So just I will take it little faster. This is the one knot and this is the last knot. That. So it is over. Sometimes we do the injury of the bladder. Bladder injury is very common. If you are using energy to push the bladder, here we can see that surgeon is pushing the bladder with the energy, and that is a big problem, and you should not do like that. You should do blunt and you should go lateral to medial. You should not start medial lateral. Lateral window should be formed. Here we can see bladder is already opened, and here we can see this is Foley's catheter. So surgeon has pushed by the energy. He has used the electrosurgery to do that. So that should not be good idea. But if it happens, no problem. Thus you can try to suture. Single layer you can suture with the Vicryl and keep the Foley's catheter for 14 days. It will heal nicely. So injuring to bladder is not a problem, but you must try to suture it. So it is repaired. I am taking a little faster because your lunch time is already happened. And it is sutured. Interrupted or continuous, both can be done. And we can see it is done. It is nicely sutured. Now this is another case. Here surgeon is using the scissors to separate the bladder. This is also not a good idea. And remember, fat belongs to bladder. This is a rule that fat belongs to bladder, fat belongs to rectum. He is pushing the fat towards the vagina. That is bad. It should be pushed up towards the bladder. And once he is doing like that, slowly, he is separating by the scissors. And that is not a good idea to do. And fat he is keeping towards the vagina. So that is a mistake. And then slowly, see, he is about to open the bladder. And this is a sharp scissors which is used to separate. And it is already opened here. So this type of mistake, if it happens, it is due to our technical problem and should be avoided. We can see here, this is the bladder and Foley's catheter will be visible. So here is the Foley's catheter. So it is recognized, but good thing about that you will immediately suture it. So here it is suturing. And once you suture it, it will heal. So thanks to the bladder, because it has such a good blood supply, that if it is immediately sutured, but take care that you should stop the hysterectomy and first repair it. Because if you will remove the uterus, after that suturing will be difficult, recognizing it also will be difficult. So this is suture. So suturing part I am just taking faster. And you can see here 3 interrupted suture was given, and that's all. So this is also one of the injury. What is the advantage of doing TLH? That is less pain, early recovery, minimal hospital stay, thorough diagnosis. More complete excision than the vaginal hysterectomy, reduced incidence of bladder and rectal injury, less chances of wall prolapse. This is one of the big advantage plus over the LAVH, NDVH or abdominal hysterectomy. Because any other hysterectomy, you have to cut completely uterosacral ligament, which is not required in the TLH. So less chance of wall prolapse. One of the biggest disadvantages that is the ureteric injury. In the American Journal of Obstetric Gynecology, is very old, 1998. It was published 4.3% ureteric injury happen. But if you will use this infrared ureteric catheter or ICG, then it will not happen at all. So these are some of the disadvantages of the. So this is your previous batch, and last day we also have celebration with the hood and gown, and you will have certificate. And this was the one older batch. So thank you very much. Now, is there any other question regarding the
Is there any
company?
other question?
Now
I think not, sir.
I will ask one question. That white tube has to be removed always in TLH.
Why the tube has to be removed always? You mean fallopian tube, right? Yeah. Sorry?
Yes, that is correct. They are saying that it is a cause of the ovarian cancer. This is one, and another cause. Another is ectopic pregnancy. Do you know there are hundreds of cases of ectopic pregnancy reported after TLH? If you will see the literature, you will type TLH and ectopic pregnancy, then it happens a lot. So, ectopic pregnancy after TLH. So, you can see a lot of literature is there. Like one of them which came on the top, I have opened for you. Ectopic pregnancy after hysterectomy may not be so uncommon. It is common. He is writing in little twisted manner that may not be uncommon, but the meaning is it is common. And in many cases, 2 years later, in one case 11 years later. Do you know why? Because these all are 4 years after hysterectomy. You can see here, 4 years after hysterectomy. In one of the cases, 11 years after hysterectomy. Why? What is the reason? That sometimes the gynecologist may not have a good suturing skill in the beginning. And when they close the vault, a small opening exists. And through that, a sperm can enter inside, and if the tube is there, it will enter into the tube and it can form ectopic. So that's why vault should be nicely closed. Some of the people, they don't close the vault. They say vault closure is necessary. But ideally, vault is closed and it should be nicely closed. Otherwise, chances of ectopic is also one. It is not very common, but it is not so uncommon also, which you have seen in the literature. So that's why we should always remove the tube in the TLH. So thank you very much. So just I'm leaving Dr. Solomon.
Yes, sir.
Can we stop now? Any other question?
Yes. No. So just the next presentation probably in 45 minutes.
Okay, thank you. Thank you very much. Thank you. Thank you.
Oh, wait.
Thank you, everyone.
There's one more.
Thank you very much.
There's one more question, sir. regular suture, but is there any need to use barbed suture, sir?
Barb suture is good. You can use it. Only advantage is you don't have to tie a knot. But there are two disadvantages of barb suture. One disadvantage is the cost, because it is expensive. Another, that few cases of fistulization has been reported. Because this barb, if it is projected little bit, it can anchor the momentum or bowel. Adhesion chances with the barb suture is little high. So only advantage is you don't have to tie a knot. Just you keep on taking a bite and cut it at the end. Otherwise, I don't think that it is necessary, especially in developing country. And this barb is over advertised the company, because company want to sell it more, and they are promoting a lot of literature in the favor of the barb suture. And surgeons are looking for that because they want shortcut, they don't want to tie a knot. But it can be used. If it is available, there is no harm using. Only few cases fistulization is reported. If you will put in the Google or ChatGPT, you will get the literature that fistulization after barb suture. So that fistulization complication of barb suture. This is a problem. See, here it is written. Fistulization is a rare complication of barb suture, where suture material forms an abdominal connection between two organs, often causes barbs to hook with the tissue. It hook on the tissue. Because this is a hooking property that doesn't need knotting, because that hook is holding. So anything come in the contact of that hook will held. And then adhesion and fistulization. So this is over marketed to make money by the company. I don't like barb suture. Even for myomectomy, we don't use it. Sometimes use, rarely, but it's over propaganda of the barb suture. And it make you lazy. It make you lazy because you don't regularly tie the knot.
Okay.
So
Perfect. Thank you, sir. Thank you.
thank you very much. Thank you everyone for listening. Thank you very much. Have a nice day.
Thank you.